It off. And so welcome, great to connect with you all. I think I know most, if not all of you, but my name is Lisa Marsh and I'm part of the Northeast node of the CTN and serve as a co-chair of this youth special interest group. And I'm delighted to briefly introduce our presenter today, Dr. Marina Toulu-Shams, and she is trained as a pediatric and forensic psychologist and is a clinical scientist, and she is at the University of California in San Francisco, so it's bright and early there today, and she leads there a juvenile justice behavioral health lab. The mission of this lab is to improve behavioral health outcomes for youth who come in contact with the juvenile justice, child welfare, and foster care systems. Incredibly important work, and her work that's funded by the NIH focuses on improving youth's physical, mental, and emotional health, reducing drug and alcohol use, reducing behaviors that place kids at risk for HIV or STIs, and increasing access to evidence-based care. And she has a particular emphasis in her work on leveraging technology to achieve these outcomes. And this, as I understand it, is going to be a central part of her presentation today to highlight for us some of the work that she's been leading, leveraging technology to advance behavioral health equity in juvenile justice. So we are delighted to have you here. Thank you so much for joining and sharing your work with us, and we will turn it over to you.
Thanks so much for that kind introduction. And it's fun to see some familiar faces who I feel like I've seen in a little while. So, and also UCSF colleague. Hi, Veronica. And other names I see here. So really fun to be with you all today. And so let me go ahead and share my screen. Okay, sorry, I'm in the wrong place in my talk. One sec. Bear with me. We were testing my sound earlier, so I ended up on a different slide. There we go. Okay. Okay, can everyone see that now? Yes?
Yeah.
Okay, awesome. All right, so I have no disclosures, and I want to, okay, let me just start by just giving a quick overview. These are some of our projects in our UCSF Juvenile Justice Behavioral Health Team Lab at Zuckerberg, San Francisco General. And today I'm going to I'm not going to talk about all of these projects, but these are various projects that we have funded in the space of how to leverage digital health technology to increase access to substance use and mental health treatment for system impacted youth. I'm going to talk about a few of these today because I really would love to really talk more about what the challenges have been in doing this work and how we think about this and moving the research forward. But to set the stage, I'm going to talk about one project, Project EPIC, that Lisa, you and I were just talking about, to really just set the stage for why we're doing this work. And none of the slides that come after this could be happening without all of these funders and this entire team who you see. This is our lab Bitmoji, and we are grateful to be continuing to add amazing team members who are supporting doing this work. And of course, the National Institute of Drug Abuse and National Institute of Mental Health and other foundation and philanthropic supports. And then, of course, the youth and families who share their time and experiences, who I'm hoping to introduce you to some of through talking about these projects. So I'm just going to give a quick sweeping overview of the juvenile justice landscape and reform. I don't know how many of you are familiar with that piece of things, but it's important when we're talking about the focus on youth who are system impacted and involved and in the community. I'm going to talk briefly about mental health and substance use as intersecting risks. I think this group knows that work quite well, but maybe not as much specifically to this population, and barriers to treatment access and engagement, which is really what propelled us into this work. Even we started this pre-COVID, which is part of what I'm going to talk about, is how we assumed maybe COVID would make this easier. And it's brought up a whole new set of challenges when we're talking about using technology to increase access to substance use treatment for system impacted youth and families. So we're in the fourth wave of juvenile justice reform right now. And that fourth wave, just very, many of you know about the super predator and the mid-1990s and what happened about clamping down and saying all youth who are violent offenders and deserve to be locked up. And we swung the pendulum, thankfully, in a very opposite way now, where the focus is really on understanding adolescent development and how that relates to behaviors, as well as bringing in trauma responsive and trauma informed practices to juvenile justice systems. We have a lot of work to do on research around implementation of those trauma informed practices, especially when we're talking about transforming the systems to be more trauma informed, but the pendulum is going in the right way. And so, and related to that, these are older snapshot data, but we continue to see that placement rates, and now they're calling in California congregate care, but we see more and more, fewer and fewer youth getting detained or incarcerated. But what we still see is a very high overrepresentation of ethno-racial minoritized youth in the system, and that continues to persist. Despite the reduction in the number of youth who are held in facilities, we still have almost 50,000, a little over 50,000 young people who are taken from their homes as a result of some type of legal involvement. And so we have a lot of work, and we have a paper coming out that is in Frontiers that I'm happy to share, that is really a piece looking at how detention facilities, congregate care have a lot of work to do to leverage technology and telehealth to provide family-based intervention, which is really the gold standard for substance use and recidivism for these young people. In California, we have really swung the pendulum in very exciting ways in thinking about how do we become the first urban center that does not have a detention facility. You can see these dates, they're 2019. In 2019, the Board of Supervisors pledged to close Juvenile Hall. For the 2 years between 2019 and now, I served as co-chair of the mental health subcommittee for this Board of Supervisors working group to close Juvenile Hall. Yes, COVID happened in the midst of that, and I can share more about this process. But what has resulted was just even last night, an article in the San Francisco Chronicle as to why we were scheduled to close last year, December 31st, 2021, and why are kids still locked up there? We have 11 youth currently. The census is very low. However, there are very political, financial, and very complicated reasons as to why there is not a full closure. And primarily it's because of legal statutes that require certain types of offenses or acts to be in a secure facility. And because of COVID in particular, we were unable to yet figure out how to build or where it would be built to have what are small home-like residential facilities that are going to occur. But this is a final report, 88 pages. And what I will say to you that came out of the final report that shows how much more work we have, emphasis on substance use, no matter how much we advocated in the mental health subcommittee and otherwise, is very minimal. And so there's lots of reasons why that is that I'm sure you all know too in your work around stigma and politics and community, but suffice it to say we have a lot of work still to do in the community around access to care for system impacted youth and families. So what about the intersecting risks of mental health and substance use that make this so critical? Well, work that we did in the Rhode Island Family Court Mental Health Clinic shows that youth who have a co-occurring psychiatric and substance use disorder were 6 times more likely than their non-dually diagnosed peers to have been detained over a 12-month follow-up period. And we actually have another paper coming out in JAPL soon that is replicating these findings with a broader epi sample of youth in first-time court contact from Project EPIC. And what we see too is the impact of sexual abuse and trauma. I think I'm telling you all things that you already know. young women disproportionately impacted in terms of sexual abuse and recidivism. So I'm just going to present to you some data from a sample of 423 first time, and here and in our some of our earlier publications and in the grant, we've referred to them as court-involved non-incarcerated. Now, I want to say, like, there's not a lot of work that's focused on large samples of youth who are involved in the legal system, the juvenile legal system, but are housed in the community. Most of the work was focusing on detained youth. So this is the only study outside of the Crossroads study, which was a multi-site study in Irvine, Louisiana, and oh no, I'm blanking on the third site, but a longitudinal study of youth with a first-time status offense, and did not include girls. And so this sample focuses on youth within a month of initial court contact. And the other novel piece of this sample is that we have both caregiver and youth data. So these are dyadic data, and our study was based on eco-developmental theory developed by Jose. So we have multiple concentric circles that we're looking at influences of trajectories of substance use, psychiatric symptoms, recidivism, and sexual and reproductive health outcomes for these young people. So they were enrolled from 2014 to 2016, and we followed the dyads for seven time points over 24 months. Also, I should say, I can't see the chat right now when I'm going. So if someone has their hand up or has a question in the chat, can someone let me know? That'd be great.
Sure.
Okay, thanks. Okay, just want to give you a sense of what this sample looks like in terms of demographic and other factors. What you can see here in the main points in the red is that this sample of youth in first-time contact reflects the same overrepresentation of ethno-racial minoritized youth as every other legal sample of youth. And so in the area that these data were collected, this proportion of Latinx youth and families, 44%, is double that of what the census was at that time. And the same for Black, African-American, or Haitian, and way underrepresented for white youth. This was a largely public, the sample 65% were receiving public assistance, and 40% had an IEP. So just to give you a sense, and the sample was 50-50 male and female pretty much. And the reason for that is because we intentionally split the sample to enroll half youth who had a status offense as a first-time offense, right? So truancy, curfew, something that's illicit by virtue of them being underage, and then half who had a first-time delinquency offense or petition filed. And so what we know in the status group is that the girls are more represented. So typically in these samples, you'll see like a third female and 2/3 male, whereas this, because of the inclusion of young people who had a status petition, you'll see that we have more young women. All right, just to set the stage for the interventions that we're developing now, this is a group of young people coming into first time ever contact with high rates of psychiatric diagnosis, a third psychiatric medications, recent to study entry, 17% psychiatric hospitalization, and close to 15% had clinically significant internalizing or externalizing symptoms. Very high rates of trauma right at the front, first time contact with the system, and an average of 3 ACEs. And another paper that we have published has shown that these ACEs at the first time contact are predictive of significant psychiatric needs 12 months later. So there's a lot of opportunity for intervention at this first time point of contact. In addition, around suicide, prevention as well, which Kathleen Kemp at Rhode Island Hospital and Brown is continuing to do some really important work around. Substance use, it's high. These are young people, average age 14 and a half years. I'm sorry, I didn't emphasize that. That was in the other table. 50% are endorsing having ever used cannabis, and a third alcohol, and 13% other drugs. And if we start to look at kind of overlapping areas of need, and we did some analyses looking at when you have co-occurring risks, substance use, and sexual risk, that was defined as any type of unprotected sexual activity, not using condoms, not having any type of barrier. When you look at that, at co-occurring risk, and you look at psychiatric symptoms or psychiatric needs and trauma symptoms, you see this linear relationship such that young people who don't have sexual risk or substance use behavior have the least psychiatric need in terms of having lower affect dysregulation, reporting fewer delinquent acts and fewer trauma symptoms. And when you go to the other end at co-occurring risk, so both sexual risk and co-occurring risk, you see the highest amount of need. So we know that these are overlapping needs, and that we need to think about integrated approaches to intervention as well. And then why are we focusing on this population of youth? Well, part of it is because the waves of juvenile justice reform, the more young people we have out in the community, the more we need to build the community's capacity, right, to provide that care. And prior studies focused on primary prevention, like the Pittsburgh Youth Study, so before any contact, which is very much needed. Other studies looked at tertiary prevention, so the Pathways to Desistance studies looking at very serious violent youth who commit very serious violent offenses and following them from that point. And our group really felt that there was a need to be looking at secondary prevention, right? So for young people who come into first-time contact, how do we keep them out of the system? How do we prevent them from going from intercept 2 all the way to intercept 5? And one way in which we feel strongly is to build interventions in the community and build capacity in the community to address unaddressed substance use and mental health needs as a way of combating continued entry. Now, we know there are multiple other influences on system involvement. So I just want to acknowledge that here. And before everybody got on, I was talking very excitedly about, we just got funded to do a follow-up study of Project EPIC. Like literally it started this month. We have an R01 where we're going to now be following our dyads into young adulthood for the young people. And we're going to be looking at behavioral health service utilization as young adults. And we have a very unique opportunity to look at structural racism, sexism, and economic inequality in relation to past trajectories for these young people as part of the original sample. And we're going to be able to look at a statewide level, the impact of these structural factors on trajectories of substance use, psychiatric symptoms, and recidivism for this group of young people. And so I just want to acknowledge here that today we're going to talk about technology as one slice of a way to increase access to care and reduce recidivism, but these structural level factors are equally as critical to understand and research in terms of intervening in these factors. Okay, barriers to care. We looked at our sample from Project EPIC, and what you can see here is that those who used services actually experienced greater barriers, which in some ways you might understand about when you see what they are. So agency program issues. So the biggest barrier was that wait lists and not having access once they got connected with an agency. And then mistrust of medical professionals and transportation issues were the other two that kind of highlighted for us, okay, we need to think about providing a way for access to care while they're dealing with these referrals for wait lists and other issues that are blocking access to care. And what you see here, we looked at these barriers according to caregiver, race, and ethnicity. And what you see here is that by and large, ethno-racial minoritized families are experiencing higher rates of barriers to care. So way back in 2018, seems like ages ago, we started to think about how do we build the case for adapting emerging technologies for justice-involved youth. And with Erica Bath at UCLA and David Farabee, we wrote this paper kind of talking about various recommendations. And this was kind of the start of thinking about these technology pieces.
Can I jump in with a quick question? Sorry.
Absolutely.
There's a question in the chat. It says, is time referring to lack of time for the individual or family?
Oh, thank you. So the lack of time was driven by the family, like the caregiver and the youth each responded to the item, but I was presenting the caregiver. Yeah.
Thank you.
Yeah, good question. So why digital health? I know that I am sharing information that you are all very familiar with. So I'm going to kind of blow through this part, especially as why digital health. But, you know, at that time, it's like we have barriers to access and engagement for this population, disparities in access. So I showed you perceptions and stigma, which we haven't talked a ton about, but it's replete in the literature. And then evidence-based practice implementation challenges. So specific to this group of young people and care access, there have been trials, very large scale trials of substance use treatment implementation studies and various other types of implementation science trials to increase evidence-based substance use treatment within these settings. So you all are familiar with JJ Trials, done phenomenal work around how do we think about implementing substance use treatment in the community and in residential settings and other care settings for justice-involved youth. And one of the things that really, has come out of that work is how incredibly complex and challenging it is to do this in the community, given all of the nuances and differences in referral practices and system practices. So we've started, this is why we started to think about, okay, well, how can technology perhaps hold some promise for this group of young people? And we started off with a text messaging intervention, a pilot, which we wanted to understand how might text messaging actually help to enhance service utilization. So for young people who are referred to substance use treatment from probation, how might text messaging to both the youth and the caregiver? So you're seeing one of our themes is dyadic work, which is not so typical and brings its own set of challenges. And we wanted to understand, would this actually be feasible and acceptable? Super, super small study published in JMIR, but it was like among the first in 2019 before COVID, where we got some qualitative data from youth on probation, their caregivers, and juvenile justice personnel. And we did some really small end user testing and some surveys of this text messaging intervention. And from the qualitative work, we found that texting was happening at that point between probation and youth and families. It was common, but it wasn't systematic. So sometimes like POs were texting kids while they were at school, like remember to go to this appointment or doing a general supportive check-in. But there were lots of barriers to use that the youth and families raised. They straight up said, don't use words like mental health, don't use words like substance use in my text. They're worried about their caregivers seeing their phone and they can't trust who's on the other end. And then for messaging format, they were very clear, short, but frequent, and don't want it to seem like it's coming from a robot, and we want it personalized. So basically, in this very small pilot, we gave them text messages for 6 months, automated appointment reminders 3 and 1 days before on the 1 day before and on the day of. And we had these pre-scripted motivational messages sent twice a week. And here's some of the sample motivational messages. So the youth got a message and the caregiver got a parallel message. And they were things that were designed to really provide positive reinforcement and motivation. Things like, keep your head up, stay positive. And then for the caregiver, one small positive thought can change your whole day. We did refer about making appointments, your success in the future equals making it to your appointments in the present. Similarly for the caregiver to support the young person. And we got information from the youth and the caregivers about, how acceptable they felt these messages were. Did they like them? What did they think about the intervention? And again, super, super small sample, but basically the youth received the messages for about 6 months, and they all felt it helped them attend their treatment appointments. They liked the ability to read the text messages at their convenience. They saved the reminder on their phone. We only had 2 caregivers involved. So this is a whole nother issue about the dyadic recruitment. But they liked it. So we said, okay, we got to figure out how to, one, actually confirm that they're attending their treatment appointments, right? Because we didn't actually collect treatment appointment data to see if this had any impact, right? And do this with a larger sample. And we thought too, we really need to start thinking about the ethics of doing this work as well, like the next steps on research on guidelines about privacy, confidentiality, and information. And related to a lot of the systems and policy pieces I was bringing up earlier, we need to think about hybrid type research designs that explore the efficacy of the text messaging on treatment outcomes while also studying these system and policy level factors. So this is where we are right now, Project Text 2. And I'm going to talk about this about COVID and how we've had to pivot. But basically, as part of my K-24, we got funded to do a larger, and I say larger, but it's still a pilot trial of the Text 2 intervention. And I have the recruitment video up here because this is one of our approaches to recruiting. But I will just give away the punchline right now that we are still, because of COVID and the challenges that I'm going to talk about, we're still in aim 1, trying to finalize the intervention with a large, because we only had 2 caregivers with the first pilot, I really wanted to make sure that we're really getting caregiver input into this dyadic intervention before we launch into the pilot trial with 60 caregivers and youth randomized. So I'll just play this for a second so you can see, but this is one of our recruitment videos that probation officers can play to families to refer them.
Hi.
Hello.
Thanks for your interest in the Text2 research project. My name is Evan Holloway.
And my name is Ifi Ezamora, and we work for the University of California, San Francisco and the San Francisco General Hospital. The principal investigator for the Text2 project is Dr. Marina Toulu-Shams.
We want to provide you with information about our research study so that you can decide if you would be interested in participating.
If both teen and caregiver agree to participate, we would send you text messages and other content to help keep you motivated to attend counseling appointments.
You would also both fill out a survey at the beginning and after 30, 60, and 90 days of your involvement in the project, as well as a short interview at the end, so that we can learn more about you and whether or not you thought the text messages were helpful. We would pay you with a $30 gift card for each survey and the interview. So by the end of the study, you could each earn up to $150 for a total of $300.
Like I said before, we work for the University of California, San Francisco, and our project is completely confidential, private, and separate from anything having to do with your involvement with the court or probation.
If you are not interested, go ahead and click the Not Interested button. But if you are interested, please click the Interested button and provide us your contact information so that we can follow up with you soon.
If you're not sure, or if you're having any problems with the form or have any questions, please call or text us at 415-361-0805.
Thanks for your time.
And we hope to hear from you soon.
So we were hearing from probation and others that they really wanted a shorthand that they could just play for families rather than having to explain the project possibility to them. So that's how we came up with that. But I'm going to talk next about, about what happened next. This thing called the global pandemic that we all were confronting. And we suddenly found ourselves having to pivot. And, I'm really curious to hear about others' work in this space, because what we found with our system impacted youth and families was that the youth just were not getting referred at all, like during COVID. So the CBOs, in addition, were really struggling to implement any sort of telehealth treatment. So it's like, I know everywhere shut down, but what happened for us around this and what I'm learning from others around the country is that for the system impacted youth and families, it stopped during the lockdown, but it really hasn't picked back up again. It's just kind of, the youth substance use decreased temporarily due to lockdown, but in-person monitoring like completely disappeared. And with that, we have seen like monitoring period decline, at least in our jurisdictions here in the Bay Area. So all of a sudden we were doing a services utilization study, right? This is a health services study to figure out how do we engage young people who are referred in need of substance use treatment, and our outcome was now affected greatly by young people not getting referred at all because they're not getting identified in the same way. So we had to pivot, and we had to think about things like removing appointment reminders, for example. So if these young people are using, but they're not necessarily getting referred to treatment, then the appointment reminder piece isn't as relevant. We had collateral data collection for appointments that we were collecting through electronic medical record. Because we needed to expand sites, which I'll talk about in a second, we're not able to get that collateral EMR data in the same way that we had anticipated. So now we're relying on self-report, which is less than ideal for the young people, but it's a start. It's a start. And if we're getting that self-report too from the caregivers around treatment attendance, then we figured it's a start. We really tailored the dyadic messaging much more so that we could get at some of these motivational factors. So for those of you, I don't know how much you know about the health belief model, but there are these different growth domains around barriers to care, benefits to treatment, cues to action, self-efficacy, susceptibility to illness, and severity. These are kind of like different growth domains. And what we're doing now is we're asking the young people and the caregiver to identify, like, where would they like to start? Like, what area to them is, most important? So are they feeling most overwhelmed by barriers? Are they wanting to understand and know more what they need to achieve certain goals? Is it more around their beliefs in their ability to improve, reduce their substance use? So we are really kind of targeting more in on the motivational messaging at this point, and hoping that's going to give us some more fine-grained kind of information and data about what might motivate young people to engage in care and reduce their substance use. And we've expanded our site. So with technology, there's no limit to reach in many ways. And so we now have expanded to a probation site in Pennsylvania, but now we have expanded to a national sample because we're no longer tied to the electronic medical record outcome data. And we're just really interested in understanding, can we increase and enhance young people's motivation to engage in care for those who are referred? And while it's not happening so frequently in our jurisdictions here in San Francisco and around the Bay Area, we are hoping that this social media recruitment has been very challenging. That's like a whole nother talk that I would love to talk to people about, but that has come with its own set of challenges. But right now we have 7 dyads enrolled who are receiving the text messaging. These are youth on probation or justice involved in some way in their jurisdiction and have been referred to substance use treatment according to their self-report. So we're making our way, but I don't yet have data for those 7 because we're still in like their interview and assessment phases for this first part. Okay, when I talked about the hybrid piece and the need for the systems intervention, this is the other aim of the Text2 project that created a life of its own once COVID hit. So this Youth Justice and Family Wellbeing Technology Collaborative started off as what was supposed to be a quarterly collaborative meeting of 15 to 20 system stakeholders from child welfare, juvenile courts, PD, or public defender, district attorney, Department of Public Health, behavioral health CBOs, San Francisco Unified School District. And the mission for this collaborative was to develop and implement cross-system technology interventions to improve youth and family behavioral health services access and outcomes for dually involved child welfare and juvenile legal system involved youth. And our goal was to increase the system's capacity to develop projects that leverage technology to increase access to care and to enhance and grow, particularly organizational readiness to adopt various technologies. And what happened was we started in January 2020 and COVID hit. And these stakeholders, so I co-chair it with the head judge of the San Francisco Unified Family Court. And basically everybody wanted to meet monthly. And we have now been meeting monthly for over 2 years. And we have accomplished multiple projects in the space of using technology to increase access to care. And so we have continued also to do qualitative interviews, as was proposed for this third aim, with probation stakeholders and others to understand ways in which we can integrate technology into the systems to improve access to care. But this project, this aim in and of itself has been really critical to understand some of the systems factors that impede or facilitate the implementation and adoption of technology for substance use, treatment access, mental health treatment access. And we have a paper coming out actually that describes these themes around barriers and facilitators to implementation and adoption of technology for these youth and families in these systems. But I just kind of wanted to point this out because you never know what's going to happen. And this really has taken on a life of its own, like I said. And right now, for example, the collaborative is working on a project that is a data sharing project across all of these systems for dually involved youth, such that, and we're partnering with a tech company where the judge can put in a youth's name and up pops everything about that youth's behavioral health services history and their educational and their child welfare involvement, such that the judge can have that information at their fingertips to make an appropriate disposition. Now, there's a lot of nuances and layers to that and using the technology for that we're working through, but these types of data sharing platforms and technological advances to be able to stop these leaky gaps in cross-system care coordination have the potential to really, I believe, have the potential to transform access to care and the appropriate care and matched care for these young people that will ultimately help to keep them out of the system. But we have to research that piece too. So once we develop this tool, we will be researching the adoption and implementation of it and associated outcomes. But that's just to give you an example of something that this collaborative is working on. And this collaborative has held now and has seeded various other projects that are leveraging technology to advance access for these youth and families. So we have a family navigator project that's for foster care youth and families that uses an app that was co-developed with the navigators who are in the foster care mental health clinic, the staff, and the youth and families, that is to facilitate care coordination and navigation and communication between the navigator and the youth and family. And we're in the midst of the trial in which young people and their caregivers, 12 to 17 years old, in the foster care mental health system, and receiving mental health services, which could include substance use, they are randomized to either get the foster care family navigator plus the app, or the standard of care, which is a phone call from a case manager to link them to care in the community. And we're going to be evaluating the impact on their linkage to treatment in the community, their retention and care, these what we call cascade of care outcomes. And we're going to look at that and see what the impact is on the system and services utilization. And the Family Telehealth Project is another tech project in which we're delivering a family-based intervention through telehealth for youth in foster care or who may be dually involved, who are placed out of home, out of county, and can do this intervention with their caregiver of origin. When I was talking before about how we need interventions that focus on family-based interventions through telehealth for youth in detention, that's one of the projects I was referring to. So, all right, the last thing I want to show you is, as you can tell, we're trying to tackle this from multiple different angles. And that's the piece where I'm really hoping we might be able to talk about, because this work really requires multi-system, multi-level, flexible interventions. And one of the things, and we're constantly building on what we're learning. As many of you who are already doing this work, I'm sure Lisa and Ranjan and others can really talk about this. It's like a daily learning process with this work at the intersection of public health, psychiatry, and technology. And I don't just mean like the technology learning curve. I mean, like, how do we think about how to do this in an evidence-based informed way that's actually going to make an impact in the real world. And so one of the things that we quickly learned with our foster care family mental health navigator project, where we co-developed it with the youth and families, is that the teenagers went to the Navigator app that was developed, that was largely led by the caregivers. Caregivers love it. They're like, oh, this is so helpful. It's organizing and getting in touch with the Navigator. And so we said, well, we got to think about engaging with the young people and developing something for them where they could have immediate access to care and their own personalized kind of navigator and care. So we have been working for the past 6 months with a group of foster care involved young people who have either previous or current lived experience in the foster care system. And we have hired them. They're part of our team, and they have been co-designing and co-developing an app that they have called Foster Space. They have been coding with us, developing it with us, And I'm going to show you a demo of Foster Space. And then I'd like to show you a video testimonial of one of our co-designers about why he wanted to get involved in this. But the app is a space solely for foster care young adults, those who are in extended foster care, and we're working on 16 and 17-year-olds having access to this too, but they get access to curated resources for foster care youth. They get access to an in-person, through telehealth, but a live navigator who can help them access these resources. And depending on their emotional wellness, mental health, substance use related needs, can have direct access to a clinician to begin treatment. So let me play this for you. So one of the things that, one of the things that, we're right now we just launched this. So our goal is to, basically we have 4 users right now. We have 4 users. Our goal is to do a pilot with 30, and in particular to really be able to look at uptake, to look at time to access to care for those who need it in the app. And as part of the evidence-based treatments that where all the clinicians are trained in the unified protocol, and we will be able to deliver MET CBT as well through telehealth and our various other evidence-based interventions for mental health and substance use that our clinicians are trained in through UCSF. So they basically get access to the UCSF services immediately for those that need it. But you can build something, and it's one thing to build something, it's another thing to actually have users, right? And one of the things that we're already seeing is that this kind of push for we kind of blasted it like around the Bay Area and in social media, and we've gotten 4 users. And so one of the things that we're thinking about right now is that this may really be, the need may be, despite what you'll hear from the co-designers, that this is the only app that tailors to foster care youth that they're aware of, that for mental health and substance use treatment needs and resources and navigation. But that doesn't necessarily mean it's going to be utilized by a wide swath of young people who are signing up. And so what we're thinking about is that this is possibly something that we really need to start partnering, right, with CBOs, with foster care clinics. Like even I was thinking about our adolescent medicine clinic at San Francisco General Hospital. And so that providers are utilizing this as an option for their young people in their care, and that may be a way of increasing access. So it's not like, the technology, we build it and now all of a sudden we know that there's a really good article recently in JMIR about what happens around engagement with apps. And so I just wanted to bring that up because that's also in the very nascent stages of evaluation and data. So I'll just play this in closing because it's so important to do this work from a community engaged and participatory informatics approach, which is how we approach all of our work. And I didn't talk about that a lot, but it's like part and parcel of what we do. I want to just play this testimonial and then open it up for questions.
I've been in the foster system since I was about 6 years old. And so, I mean, fortunately, I wasn't alone. I had my 3 other siblings with me. Obviously there's other people who aren't fortunate to have siblings, or have someone, a best friend, to really just be there through that hard times in their lives. But, with this app, the goal is to provide that, whether it's a fellow foster youth or a clinician or a navigator, just someone to share their life with in a way and kind of find purpose and meaning in that. And so one thing that I really want to emphasize through this app is just that your trauma does not define you, life is hard, but there are so many ways to make life a little bit easier. And with this app, it's definitely made my life a little bit easier just to know that there are others in my community who have been through similar, events and, have struggled with mental health. And, I really just want to make a community out of this and let other foster youth know that they're not alone in this and that they have a voice. And yeah, it's been great.
So that's JJ. Awesome, been an amazing contributor. So I'll just close by giving you some examples of next research steps. I don't know if you can see the common theme across the top here, but evaluate, evaluate, evaluate. The more rigorous research and the more people we can have in this space doing this type of research to enhance access to care for our passion is around system impacted youth and families who really have limited access. But these are some of the next steps that I was kind of talking about already, what we're going to do in terms of research. So for text 2, looking at the effects of this dyadic text messaging on self-reported treatment attendance and engagement. For foster space, we're going to be looking at their time to treatment access and associated psychiatric symptom and substance use reduction. And then for the tech collaborative, we're going to be looking at changes in organizational readiness over time to actually implement these, this data sharing platform, for example, that we're developing. And there's lots of other pieces to it, but I won't get to it now. I'm going to stop so that we have a little bit of time for questions. And I'm sure that I raised more questions than answers, but I welcome discussion. So I'm going to stop sharing.
Thank you so much for your terrific presentation. Wow, such innovative work, such important work. And I just love the focus, it seems like in all of your work, on co-design and community engaged sort of development and evaluation at every step. So thank you so much. It's just such terrific work. We have about 4 minutes for questions. So please, folks, just go ahead and unmute yourself and jump in with any comments or questions you might have.
Marina, can I start?
Hi, Naranjan.
Hi, how are you?
So good to see you.
Good to see you too. And great to hear all the wonderful updates on where the work has gone. So one of the things that I think we've been struggling with is the need to develop like particular interventions for certain groups and subgroups versus the sustainability issue of having these sort of individualized interventions and platforms, right? And I keep thinking and I keep pushing, although my latest trial was a complete bust, negative, because it didn't have enough cultural tailoring, right? But at least that's what we think. But the scalability of an intervention, and in your case, the juvenile justice and foster youth, to me, there's so much commonality between those populations. Could we think about interventions there? And then I want to put my homeless youth in there because they're the ones that are cycling in and out of those two systems, right? So, to what extent do you think that's feasible? And I guess one question is, do you feel like our technology building is advanced enough that we could build tailoring within a kind of common framework, right? So that's really where I'm thinking.
I'm very worried. Like, I will tell you, even with all these young people around us saying, we don't have anything for us. We don't have a space. That's how they came up with foster space. And then we went down the whole space theme. But I'm very worried about it because I am like, okay, we're just going to build something else that's going to be there for a little bit. That's going to sit on the shelf. And as we also have been training the clinicians in the unified protocol, right? It really should we be, Naranjan, that's we should be thinking about a unified protocol, technology, unified protocol for them, not the actual unified protocol, but you know what I'm saying, analogous.
Yeah.
Because I think it's a question, right?
We're looking at CETA for that purpose,
yeah,
parallel to the unified protocol. But yes, that's what I love about the unified protocol and CETA is that they are generic, right? They exist across space. And I review all these grants for study section. I always worry when people want to develop a new app or a new intervention because I'm like, how are we going to maintain this, right? And
it's so hard though, because you're right about the draw in of, the whole draw for these young people was having the opportunity to create something that is for them, by them.
But I wonder, you've got a great backbone started in some ways of the technology piece, right? And I think it's great to have the engagement from these youth. But wouldn't it be nice if we had a platform that contained all these apps?
Yeah.
And then the youth could kind of build their piece in there, right?
Yep.
In fact, if we kind of think about sustainability, what we really need is we need a big tech partner. We need Facebook to take this seriously and help us build a safe, HIPAA compliant, privacy, accorded space within their larger framework, because then we can rely on them to keep it running, right? That's the challenge you and I have with technology. I don't know, Lisa, if you feel that way, but it's so hard to keep these things current as an academic. We don't have the resources.
I think there's more room for optimism than you might think, particularly in the last 2 years within the surge in demand for digital health. There's been an explosion actually of companies and including companies with a lot of resources that are really interested in digital health solutions that really can impact people's lives, particularly in the mental health space. So I think feel free. I know we're out of time, but if our center could be helpful at all around this, there might be some folks we could link you to learn a little bit more about that. There's a lot of philanthropy in this space too, as well, particularly around venture philanthropy too, like venture capital companies putting money in the philanthropy space for digital health as well. So there's a lot going on that has really grown a lot recently.
It's true. And I should say we're very grateful for our philanthropic donor that has seeded this foster space app. But sustainability would be huge. And I like this idea of the platform with we should to be continued.
Any final quick comments? Or I know we're over and folks probably have to get to other meetings, but any final quick comments or questions? This was fantastic.
Thanks for having me. And hi,
Well,
Amy.
Yeah, I want to thank Lisa and Jose, who unfortunately could not make today's Youth SIG meeting, for co-chairing this SIG and for inviting, great speakers such as you. And we look forward to hearing more about your work, since there's so much more to come, and it's really very fascinating. And I like the fact that you're looking at it from a multi-system angle as well. So all the best, and we look forward to hearing from you.
Thank you. Thank you so much. Thanks for having me. It was a pleasure.
It was a
Bye,
pleasure for us.
everyone.
Thank you. Take
Bye.
care, everyone. Bye.